Let's continue our discussion of the 14 factors of occlusion that every dentist must know with the fifth factor, which is occlusal contacts. And what I can tell you is we'll talk about contacts. Sometimes we'll use the term stop, occlusal stop, which I'll describe in a second. But when we think about this, I don't want you to have to remember exactly where every cusp should land. But what we do want to recognize is that when we look at the upper lingual cusps and the lower buccal cusp and the lower incisal edges and the lower canines, as we think about those lowers coming in, those cusp tips and incisal edges should land on a flat surface. So the mandibular buccal cusp tips and incisal edges should be landing on marginal ridges or central fosses, something flat, and we would like to see a receiving area on the anterior teeth. Similarly, those upper lingual cusps are going to be landing on a marginal ridge or central fossa on the bottom. So the reason we use the term stop is that when cusps find their way into fossas and they don't land on inclines, those cusps will stop the tooth from erupting. If you have a tooth landing on something that's on a slant, or if it's out of occlusion, that tooth can still shift position. The goal is for whatever force the patient can generate with their muscles, if we spread the contacts over the whole dentition and get cusp tips landing on flat surfaces, we will have a beautiful distribution of force throughout the mouth. So if we have 14 teeth touching 14 teeth with equal intensity contact, that is in fact a great goal for us to shoot at. And that will go a long way to help control the system. You know, if you've been doing dentistry for any amount of time, you've inadvertently put a crown in or had a filling in where it's the only tooth that touches in their mouth. And usually that patient is back in your office pretty quickly because all the force on one tooth is a very different experience than when all the teeth are touching. So again, thinking about this a little bit further, the first thing we want to think about is the ability to idealize centric contacts. And you can start doing this on single teeth. Your next composite, your next crown. It's a very good idea before you do anything to put paper in there and just have them bite and see where the marks are. Because what we're trying to do, if it's a mandibular tooth, is we're trying to get the lower buccal cusp or cusps landing on a flat surface, and we would like the upper lingual cusps landing not on an incline or a flat surface. And so many times, staring at where these functional or stamp cusps are landing, stamp or functional cusps are the upper lingual cusp and upper lower cusps, this is always where we're going to start looking first. Now, keep in mind that when we look at our patient, most of the time when we mark our paper in there, we don't see these perfect little dots on cusp tips and on marginal ridges and on central fosses. It's not on the natural teeth, and it's certainly not often on the restorations we do. Most of the time it's like this. You may have a mark that starts on the centric stop, but it also may kind of travel up the triangular ridge. You may have part of the mark on the cusp tip, but it travels over the lingual and onto the facial surface a little bit. And what I want you to start doing is visualizing where those marks would be. So let's say you're going to be doing a composite on this tooth that's maybe an MO or something like this. Sometimes it's good to just do your little equilibration on the tooth you're going to work on before you do anything. So if you're going to take some little tooth structure away on the tooth opposing it, always get permission from the patient, tell them what you're doing. But the principle is, working on that simple tooth, is recognize where you would like the contact to be and then take everything else away around it. So it's good to first grind on the sides of the stamp cusp. So in this situation, we would grind on the side of this lingual cusp. Since this is a non-functional cusp, we would go down here and grind on the side of the mandibular functional cusps. And as we do that, you'll find that the cusps find their way into the fossa. Now, if you mark again and there's still a little bit there, you can always open up the fossa a little bit. But the rule is we always want to grind on the side of the stamp cusp first and then later work in the fossa itself. Why? Because there's more enamel on those functional cusps, and it works really good. So if you get comfortable with this concept with just single teeth, you'll find that when we start going into the mouth, this is exactly what we're doing when we're equilibrating a natural dentition to centric relation. Because again, we're going to hold the jaw back in CR. This is an example of using bimanual manipulation from Dawson. And then reading our cusps, and see right there on that slope, we don't like that, but I'm going to leave behind my marks that are on the cusp tip. A little bit of a slope there we're going to take away, a little bit there, leaving my remnant on the marginal ridge. And so initially, this is a little bit late where I'm just dialing things in, but notice, don't take the whole mark away. We're just refining where we want the contacts to be. Certainly that little smudge right there we don't need. All right, so grind on the sides of the stamp cusp first, then we're going to go and work inside the dentition itself and on the fossas and marginal ridges. All right, so the concept of equal intensity contacts or centric stops. We start looking at the sixth factor is anterior guidance. And here again, as we first visualize our centric stop, equal intensity contacts all the way around. We've talked about that nuance of non-interfering posterior teeth. Well, we're going to have to rely on contacts, lines on those front teeth. And generally speaking, there's going to be a solid line on the canine going each way, and usually balanced lines on the centrals are all we need. Now, there's some variations where you might pick up the lateral as well in protrusion, and sometimes you can even pick it up in lateral. But most of the time, the canines and the centrals are certainly strong enough. But look at x-rays, look at crown to root ratios, check mobility, all those things matter. Again, with porcelain veneers, we can do this. It's going to start on enamel and progress onto the porcelain. This is a nice example of just a good occlusion, equal intensity contacts in the back, nice protrusion, and good canine guidance in the front there. So as I said, with our variation in anterior guidance, as we go into that protrusive stroke, we may have the centrals involved most of the time. This is an example of centrals and laterals. A variation on canine guidance is having the guidance off the canine, the lateral, and the central. And this is a great thing to do if you can do it. If you got a little bit of a weak canine or a tooth that's got a big post in it that you're worried about it, if you can do this, this is great because you're still going to have muscle activity and all that. Most of the time, we'll talk about this later with group function, you're probably going to involve some posterior teeth rather than anterior teeth. And we'll talk about the problems with that, but the reality of having to do that and when and why we would do that. But in anterior guidance, we want to have a good disclusion in protrusion where the posterior teeth are separated. We want to have good disclusion on the balancing side where the longer buccal cusp gets past the longer upper lingual cusp. And again, while we'll have canine guidance on the working side, notice that the non-working condyle, because as it comes forward, it's coming down the condylar path. That helps get these teeth or these cusps past one another. So just remember on that balancing side, that condyle orbits. It comes down as it's moving towards the midline to help this disclude. And I found from my own EMG work that this type of disclusion or this type of interference, of balancing side interference, is often the most damaging. So with guidance, remember that we want to have good, stable stops on those front teeth. We have to have some coupling up there. We're going to talk about overbite and overjet here in a second. But it is why I am a huge fan of the class 1 occlusion, because if that mandibular cusp, lower canine tip lands on the mesial of the upper canine, it just sets itself up for such beautiful guidance. And so, as you're finishing your ortho cases or getting cases back from the orthodontist, make sure they finish it like this. Don't want open bites. That just totally defeats the whole purpose. Good coupling allows us to create this type of occlusal scheme where we're guiding off canines and we're guiding off the centrals. Going back to our patient, in step 2, as we equilibrate, we're going to check out those disclusion patterns. And notice we'll have them slide back and forth. And when we put this mirror in, notice right here, what we're seeing is that we see our centric stop on our canine, then we have an area where there's no contact, and then it picks up again. So we would like to have a solid line right here. But what we don't have to look far, because right behind it, we see a line on the premolar, on the incline. And remember, on a premolar, we really only want contact on marginal ridges or lingual cusps. So that's an interference. And what will happen is, as we go in there and adjust that, that will essentially allow us to clear out that lingual slope of that buccal cusp, and then we'll check it again until that line comes in nice and hard. Okay? So equal intensity contacts, the non-interfering posterior teeth. So always check, get your contacts aligned. And then, in the back of the mouth, if you marked all your centric contacts in blue or black, and you start having the patient slide around, take away any red mark that isn't where your centric stop is. And it's usually going to be on inclines. And that is a great way to think about it. Learning this, just do that with your own single tooth restorations, your composites, your crowns or your quadrant crowns. Get your centric stop where you want it, then have them slide around. And if you've got a mark on it, red mark on an incline, take it away. And that will be your baby step into really treating occlusions with precision. Number 7, we're going to look at the relationship of the overbite and the overjet. And so, as we said, and it makes sense that if we want to have posterior disclusion, there's got to be some level of coupling. And the deeper the overbite gets and the tighter the overjet gets, or the deeper the overbite, the less the overjet, generally the steeper the guidance. And the steeper the guidance may lead to problems with envelopal function, which we'll talk about in a second. But just let's look at a normal kind of interincisal angle and think about how the patient slides down from centric stop to incisal edge. And if we have a deeper bite, a really tight neutral zone, really vertical teeth, very deep overbite, almost no overjet, that is a steep guidance plane. And if that patient functions at all horizontally, those teeth are going to get into trouble. And we've seen wear patterns, on teeth like that, and certainly loose teeth and fremitus and all that. The opposite is the bimax case, where the teeth are way tipped forward, and usually sometimes those aren't steep enough. So in that case, you might not have fremitus or anything on the anterior teeth, but you might have a lot of problems on the back teeth because there's not enough guidance to disclude. So those are sort of the 3 options. I want you to think about that angle of guidance. Generally speaking, the more horizontal the load on the anterior teeth, the greater the force. And so if we think about a car going straight into a wall, that usually ends up kind of bad. If we take that wall and just tilt it down about 50 degrees and we go straight into that, it just kind of like turns into a jump. So changing overbite, changing interincisal angle, changing overjet can have a tremendous effect. Similarly, just looking at from centric stop to incisal edge, that is the angle of guidance that we're talking about here. Okay, so there's the angle that we're looking at. And, as people wear and tear and break teeth down, often we can get into trouble. And this is why, if this is the guidance angle from the person who's parafunctioning, if you were just to come in here and try to put restorations and steepen them, then often we can end up with a situation that is bad. And so that was exactly why, with Brian, I made a big deal about making sure changing vertical, making sure we increased overbite, making sure that we decreased overbite and increased overjet, that those things were going to be managed in a way that would be helpful. So here again, looking at variations as we get into provisionals, if we increase concavity, customize that envelope of function, which we'll talk about how exactly we do that. This is the way we think about it. Plan for it by thinking about overbite and overjet, but then also adjust for it when we get inside the mouth. So the guidance is steeper when overbite is increased and overjet is decreased. That's a pretty good rule of thumb. And if we're trying to fix this, remember we can affect change here by either changing the interincisal angle orthodontically. We can decrease the overbite either by intruding lower teeth or changing vertical dimension. And we can also increase overjet either by changing vertical dimension or some sort of orthodontic treatment. But as we look at our cases, it was a very big deal with Brian because remember, he started like this. And so he had worn himself down to nothing. So finding something with him that was steep enough to provide guidance, that was still comfortable for him, was huge. All right, now let's really get into two things that go hand in hand, and that's why 8 and 9 are going to go together. But it is this concept of freedom from centric. Some use the old term long centric. It's kind of gone away, so I like freedom from centric better. And then this concept of envelope of function. And so let's look at envelope of function first, and then show you how freedom from centric plays into this. So if you think about envelope of function, what I want you to think about is it's the path the lower incisor travels when we go inside and out. Anterior guidance was the path the lower incisor traveled outside. Envelope of function is the path the lower incisor travels during chewing and speaking outside in. So it's going sort of outside in. If we think about anterior guidance was the path that the lower inside traveled inside out, from centric stop out. So this lingual contour is tricky because it's got to be steep enough to exclude the back teeth, but if it is too steep or not concave enough or too convex, the lower incisors are going to bump as we chew and speak. And so to be clear, this lower incisor should be able to get all the way back to your centric stop without touching the upper tooth. And if it's not, we'll feel fremitus, lower incisors will wear, upper teeth will move, it will not be stable. So remember this rule that the anterior guidance has to be steep enough to exclude the back teeth when we go inside out, and it's got to be concave enough to be in harmony with the envelope of function when we go outside in. Really, really important concepts here. The question then becomes, if this outside-in movement is a thing, how do we find this patient's envelope of function? And we find it by understanding the concept of the freedom from centric. And the deal is, in order to find out this outside-in movement, we're probably going to have some less expensive ways to manage this. Right now we have Mod Jaw and some of these other jaw tracking devices, which I personally think are really cool, but I'm just not sure they're worth it right now. But if we could track this outside movement easily, like with things with our scanner, which I think are coming, we might be able to develop wax-ups that also will customize this as we create them. I just don't think there's an easy way to do that right now, which means that in order to really dial in long centric and freedom from centric and envelope of function, we have to do this in the mouth with our provisionals or with the natural teeth. We can certainly see centric stops and we can see incisal edges on an articulator, but what we can't determine is this concavity. What I would tell you is, just like I did with Brian, if you're going to guess as concave as you possibly can do it. Make it as concave as you possibly can to still get disclusion, and you'll probably have less to work on. But this envelope of function and anterior guidance is a really important clinical thing that we need to do, which I'm going to show you. How do we know how much freedom from centric the patient needs? So to understand this, when we lay the patient back and they're just biting, the jaw is closing on the arc, we might be helping them a little bit, and the lower jaw is going to contact in a very specific way. About half of our patients, when we sit them up and they start walking around, the mandible postures forward a little bit. This is that freedom from centric movement. And unless we build this into the linguals of our anteriors, they will come forward, and in this closure movement, they're going to be banging. And it's frustrating because when the patient may be complaining, coming back saying their teeth feel like they're hitting high, but when you lay them back, it looks normal because the jaw goes back to centric. So remember, you got to check them laying back, and you got to check them sitting up. And so a great way to do it is to go ahead and just have them sit up and mark your long centric interferences first. Then we can lay them back and do something like bilateral manipulation, or have them close into centric. And what you're going to find is you're going to see your black marks here when they're laying back, but in some patients, when they lean forward, you're going to see a smudge mark right there. And what you're going to want to do is increase the concavity. This is checking freedom from centric and giving harmony for envelope of function. So that little area right there, we're just going to increase that concavity. Showing it another way, we're going to actual patient now in provisionals, laying the patient back. We get our centric stops. We lean them forward and have them tap, tap. These are the smudge marks that you see, centric stops, the freedom from centric marks. That's what I'm going to adjust. Don't touch your centric stops. Touch the areas where you actually have contact forward of your centric stop. Again, they're bumping here. They need about that much freedom from centric to be in harmony with the envelope of function. And so all we're going to do is just get in here and just increase that concavity and make them slightly more concave. That's it. All right. So now go back and check your anterior guidance and make sure you got nice lines on the teeth. And then because you've made them slightly more concave, go back and make sure that they don't have any additional posterior interferences that you might want to clear out. So remember, as we look at this, we need our centric contacts. We need to know where our incisal ledge position is. We're going to get that freedom from centric dialed in, and we're going to get a smooth protrusive path and a smooth lateral anterior guidance. And then when the posterior teeth, we just want to make sure they touch and don't rub. Fremitus is a great check on these type of cases. Have them slide around, have them slide in protrusion. We shouldn't see any teeth flexing. That's a good way to determine stability. So as we think about the restricted envelope of function, just understand that if a dentist has been hanging around, an orthodontist or restorative dentist, if teeth have been retracted in position, too far back, or these linguals are too thick, you can create these problems. And certainly we can see this. We tend to believe that most of the restricted envelope of functions are iatrogenically created. Looking at that with a little more understanding, if you have a patient that maybe had really crowded teeth, crowded dentition, and basically too much tooth structure for the size of their arch, but they have a fairly normal interincisal angle, if that orthodontist takes out buys and really retracts those upper teeth, what we can end up doing is creating a guidance pattern, not enough overjet, maybe a bite that's a little bit deep, and lower incisors that are going right in the path of the upper teeth. Similarly, restoratively, if we start doing crown and bridge and get that lingual contour too thick, the worst is like convex, then we're going to start seeing damage. And so a lot of this, if you notice with Brian, He was a 4 bicuspid extraction case. His teeth were back. That's why I made a big deal about both the vertical and horizontal position of those teeth, incisal edges, and trying to get an overbite overjet relationship that I thought would accommodate. And yes, when we got to the point of dialing in his tempers, I had to do a little work back here. I had to dial in that envelope of function, and through that, we did it through freedom from centric. So just remember that we can only check guidance on an analog or virtual articulator. Envelope of function needs to be checked in the mouth. Freedom, and we do that through freedom from centric. So as you're doing this, and back to Brian's case, I still think we can make good guesses by making the lingual contour as as concave as we possibly can be. And it will be interesting as we move forward how jaw tracking and some of these other things may affect things in the future. Number 10, let's look at crossover. And by definition, crossover is the lateral excursion position where the lower canine moves past the upper canine. And I got to tell you, in the last 4 or 5 years, hanging back around Pankey a little bit more and watching my daughter's training at Pankey, this is definitely a Pankey thing. And I've really leaned back into it, and it's important. It's really, really helpful. And again, it's impressive looking at Brian's case in our plan here as we went from canine, and we want to see it go over the canine, miss the lateral, and smoothly go on to the central, and then similarly the other way. And if we do that, that just protects the patient that goes past their canine to start banging on back teeth, or worse yet, going over that canine and really being able to catch an edge on a lateral or a central that creates a lot of force. So I'm paying a lot more attention to this in my designs. And then, with Brian's case, we were able to really duplicate that in his provisionals. And then in the permanents, little tiny bump there, but still pretty good. And of course, we did that through our bonding on the bottom and our porcelain work up top. But equal intensity contacts, guidance in harmony envelope of function, and then crossover. The 11th factor is group function. And by definition, this is a tooth arrangement that involves multiple teeth contacting each other during lateral movements. Generally, this is going to happen behind the canine. It may involve the canine. A lot of times it's canine first bi and second bi. And I think the most important thing as we look at an optimum occlusion is just to understand most of the time we're just in introducing some equal intensity guidance angles over multiple teeth. So when are we going to do this? When do we go from one to the other? That, I think, is the most important thing to understand. It's fairly easy to do and plan for, but thinking about it in the planning stage and knowing when you're going to do it is critical. Certainly weak canines, periodontally or restoratively, weak canines, teeth with big posts in it or bone loss, you may need to spread it out over more teeth. Anytime there's an implant in the canine position, which also includes full mouth maxillary implant reconstructions, anytime you've got a canine and an implant involved in a maxillary canine, we don't want all the lateral load on that tooth. I learned shared, shallow, and splinted from Carl Misch years ago, and sharing it over the multiple tooth is the concept of group function on these cases. And then, of course, occasionally we have class 2 patients where the lower canines don't reach the upper canine. And in that situation, if the patient won't do orthognathic surgery because that is a skeletal problem, then we, of course, are going to be doing a group function. With all of these examples, because muscle activity goes higher with a group function, then we're always going to be finishing with a night guard in these cases.